actually we have designed the program in such a fashion that now we have discussed to improve the ejection fraction by 10% or more. But how to do that? So there is a debate whether we can go for a sequential adding medicine after medicine and giving a gap of 4 to 6 weeks in between to see whether they are still effective or need something more, or we should go together and hit it on the, the Billi ko mardo shadi ka raat mein aise, so kill the cat on the marriage night. So whether you attack with whatever you have got on the day one and see what happens. So with this fantastic idea now brewing up across the Atlantic, including India, we invite our chairpersons, Dr. Ranjan, Sharma and Dr. Sunip Banerjee, to invite the speakers, and we'll keep the discussion at the end of 12 and 12:24 minutes. There won't be any rebuttal. Whatever you have to say, you speak your heart out, Bappaditya and Shumanto, and then we'll discuss for 6 minutes. So Ranjan Sharma and Sunip Banerjee, please.
Yes, good afternoon, everybody. It's a wonderful program that is being designed. And now we are deviating from treatment of heart. Speakers, Dr. Bappaditya Kumar will talk on existing step care approach to be followed as it is described in the guidelines. Dr. Kumar, please.
Good afternoon, respected seniors and my dear friends. My mentor and Professor Santanu Guha sir for the opportunity. So over the next few minutes, I will be speaking on my part of the debate, the management of heart failure and reduced ejection fraction, whether we are going to follow the existing step care approach as mentioned in the guidelines. So basically, let me clarify what the debate is all about. So where we will be adding a AC inhibitor and a beta blocker at the onset, titrate the doses, then add a mineralocorticoid receptor antagonist, titrate the doses. If the patient is still symptomatic, you replace a ARNI for the AC inhibitors or ARB, and the newest entry in our heart failure armamentarium, the SGLT2 inhibitors. Whereas the recent proposed new sequencing by McMurray and the Milton Packer is that you add a beta blocker and a SGLT2 inhibitor at the initiation. Within 1 to 2 weeks, you add a ARNI, and within 1 to 2 weeks, you add a MRA. So basically, you are adding all the 4 drugs within 4 weeks and then up titrate. My talk will be basically based on the 2 guidelines, the ESC 2016 guideline and the recently published 2021 ACC-AHA consensus decision pathway. Basically, we have been following this guideline over the last few years till up to say 2019. We have been following this ESC guideline. Patients with HFrEF comes to us. We add a AC inhibitor and a beta blocker. We can give either of the 2 at the first onset and add the other within 1 or 2 days. Then we up titrate the doses. The patient is still symptomatic and EF is less than 35%. You add a MR antagonist, up titrate the dose. The patient is still symptomatic. You can substitute ARNI for AC inhibitor or ARB for heart rate more than 70 on a maximum tolerated doses of beta blocker. You add efavirenz, and in patients who are still symptomatic, QRS duration more than 130, you can evaluate for the need of CRT. Meanwhile, during all this time, you give diuretics to relieve symptoms and signs of congestion. But some things changed in the year 2019 and 20 that has led to our discussion. The publication of the 3 trials, the Pioneer HF trial, which ushered in a new era for the increased use of the ARNIs, and the DAPA-HF and the Emperor-reduced trial. Now, coming to the Pioneer HF trial, it showed that even just after admission of a patient with acute decompensated heart failure, after the patient is stabilized within hospital, within 24 to 48 hours, you can start with a ARNI. It has shown that after 8 weeks with treatment of the ARNI, there was further reduction of NT-proBNP levels, and at 12 weeks, the patients who received ARNI within the hospital had a lower risk of death and rehospitalization. This Pioneer HF study ushered in a new era for the use of ARNIs, and it is the study that has led to the approach of direct to ARNI treatment. Coming to the DAPA-HF and the Emperor-reduced trial, Milton Packer was the primary investigator of the Emperor-reduced, and J.J. McMurray was the primary investigator of DAPA-HF. I have taken these names because these names will again prop up in an important paper. This trial showed that the SGLT2 inhibitors, empagliflozin and dapagliflozin, given in patients with heart failure and reduced ejection fraction, in class NYHA class 2 to class 4 when given on the top of the established treatment of RAS inhibitors, the beta blockers and the MRS improved fairly better on this SGLT2 decreased heart failure hospitalization and cardiovascular death irrespective of the diabetic status. As a result of which, we have some new opportunities regarding the use of the ARNIs and the SGLT2 inhibitors, but there are some challenges. Where do we put the ARNIs and the SGLT2 inhibitors now? What about the older heart failure therapies like digoxin and vasodilators? And when do we refer for ICD or CRT, or when do we do a ICD or CRT? This is the paper I was talking about, Milton Packer and J. McMurray, published in the European Heart Failure Journal, the interesting paper regarding the evidence-based sequencing of the foundational drugs of heart failure. Here they proposed to initiate the beta blocker and the SGLT2 inhibitor at the first onset of treatment, then to add a ARNI and then to add a MRA. But evidences are very limited for this proposed new sequencing, and if this proposed new sequencing gains momentum, this paper is going to be a landmark paper for the management of heart failure and reduced ejection fraction. Coming to my portion of the topic, why we are really undergoing our major improvement is that there is a lot of therapeutic inertia while we are giving optimal medical management. In the CHAMP registry, it was seen that even after 12 months, there was only a minuscule amount of patients received optimal doses of the drugs. So there is a significant scope of improvement in optimizing GDMT. In a patient, in a resource poor setting of India, where most of the patients are not able to take the SGLT2 inhibitors and the ARNIs, we have to rely on the guideline-directed medical management for further improving compliance so that we can improve the GDMT in most of our HFrEF patients. In Indian population, it was seen that patients who did not receive GDMT had almost a 53% increase in mortality than those patients who received GDMT. For our GDMT, we have trial evidence of more than 30,000 patient years. We have evidences for the Paradigm HF trial, from the CHARM trials, from the SOLVE trials, Consensus trials, and lots of trials. We do not need to speak each and every trial, but there is a data from 30,000 patient years regarding the optimal medical management for HFrEF patients. Still, there is a significant mortality of the HFrEF patients, and 5-year survival is only 50%. Although AC inhibitors and NRB reduce mortality by 16 to 17%, beta blockers by 34%, MRS by 30%, but we are definitely missing something. So are we need to add more drugs? Are we needing to apply drugs in another fashion, or there is something we are missing? In fact, we are missing compliance of the patients. There are lots of drugs we are using for management of HFrEF. There is in fact a drug cocktail which increases the risk of medication errors, poor adherence to pharmacological therapies, inappropriate drug prescription, adverse effects, drug-drug and drug disease interactions, and most importantly, underuse of the effective treatment. So in Indian population, it is more prudent to stick to the established protocol of treatment rather than go to an unestablished protocol where there may be chances of drug interactions and underuse of effective treatment. In India, it is a healthcare resource poor setting. There is increased morbidity and mortality of our most heart failure patients, and quality of life is compromised. So with overwhelming heart failure and reduced ejection fraction therapies, there is a need to inform the clinicians about where evidence may be new and where there is more data is required. Numerous care gaps exist, and highlighting the need for more streamlined and efficient process implement the best practices for HFrEF patients. ACC-AHA guideline, if you go by this guideline, they recommend to either initiate a RAS inhibitor or a beta blocker. In some cases, both the therapies can be started at the same time, and this should be uptitrated every 2 weeks fashion to help HFrEF patients with optimal GDMT. This is the newest protocol they have set, the ACC-AHA 2021 guideline. This is more easy to use because they have advocated to use either of the 3 RAS inhibitors, but they had put forward a direct to ARNI approach. I will come in my later slides. Along with this, they have advised to use evidence-based beta blockers. To uptitrate the doses for patients who are still symptomatic, that is NYHA class 2 to class 4, with the eGFR more than 30 and potassium less than 5, you add the aldosterone antagonist. For patients meeting the eGFR criteria with NYHA class 2 to class 4, add SGLT2 inhibitor. For relieving congestion, you add diuretics. For persistently symptomatic patients, on all these 4 classes of drugs, you add hydrolazine, isotonic dinitrate combination, and ivermectin I have already mentioned for those with heart rate more than 70. This treatment algorithm is more feasible and more easy to use. Also, I would like to stress here is that they have applied the approach of direct to ARNI because we have already known from the Paradigm HF trial, ARNI results in 20% reduction in the primary outcome of cardiovascular death and heart failure hospitalization compared to enalapril. In the Prove HF trial, it was shown that ARNI resulted in a better reduction of NT-proBNP and caused reverse remodeling effects after 12 months of therapy compared with enalapril. Evaluate HF trial got similar findings of the Prove HF trial, and there are improvement in the echocardiographic parameters. HF already initiation of ARNI during and ADHF episodes resulted in superior outcomes compared to enalapril. All this together led to a de novo use of ARNI in our heart failure patients, and this is the result of which a direct to an ARNI approach was applied in the ACC-AHA 2021 guidelines. But we must remember, though ARNI beta blocker and mineralocorticoid receptor antagonist results in a mortality reduction of almost 63%, keeping in mind our Indian scenario where it is very much difficult for the patients to get empagliflozin and a circuitry valsartan together because of financial constraints, we can at least put the patients on AC inhibitor, beta blocker, and mineralocorticoid receptor antagonist, because these 3 drugs also cause a reduction in mortality by 56% in the HFrEF patients. Now, coming to what are the approaches of SGLT2 inhibitors. SGLT2 inhibitors put on the triple drug regimen, that is the RAS inhibitor and the mineralocorticoid receptor antagonist, extends overall survival compared to conventional therapy. As a result of which, the SGLT2 inhibitors are recommended in patients of HFrEF who are already receiving these RAS inhibitors, beta blockers, and aldosterone antagonists. Remember that the 2 trials, the EMBRA-reduced trial as well as the DAPA-HF trial, used SGLT2 inhibitors on top of this guideline-directed medical management. They did not use SGLT2 inhibitors in de novo HFrEF patients. This is the most important thing that is to be kept in mind, because if we follow the new sequencing management, here we are using SGLT in de novo HFrEF patients. So I have already discussed this. Now coming to the explanations put forth by the rapid sequencing group, they tell that the traditional sequence does not necessarily conform to the known relative efficacies of the available drugs. But our counter argument is that GDMT has evidence from studies more than 20,000 patient years. The new sequence proposed does not have any RCT evidence for benefit. It is backed only by expert opinion extrapolated from other related studies. Also, after the introduction of the direct to ARNI approach and the SGLT2 inhibitors in GDMT, there has been further evidence-based improvement in outcome of the HFrEF patients. Another argument is that even low doses of the drugs afford significant benefits, whereas the escalation of dosage adds only marginally to the efficacies, whereas initiating multimodal treatment, even in low dose, may exert greater beneficial effect. Our counter argument is that in GDMT, multimodal treatment is used in a more scientific way, backed by evidence. There are affordability issues with ARNI and SGLT2 inhibitors in the Indian population. At least a patient can receive a ACE inhibitor, ARB, a beta blocker, or a mineralocorticoid receptor antagonist. In the Indian population, where compliance is a major issue, instead of jumping to a new unestablished protocol, it is more prudent to follow the standard GDMT with an emphasis to improve compliance. And another opinion is that SGLT2 inhibitors may have a better safety and tolerability profile if we follow the new approach, because they can reduce the renal dysfunction associated with the RAS inhibitors, or they can mitigate the risk of early worsening heart by the beta blockers. But our counter argument is that without following a standard protocol, there is increased risk of adverse effects, metabolic abnormalities, renal dysfunction, and drug-drug interactions, and cost issues. Moreover, the 2 trials, DAPA-HF and the EMBRA-reduced, studied these SGLT2 inhibitors in patients who are on GDMT for HFrEF. This is the Canadian guideline. What they have proposed, I like this guideline because they have not discussed whether we are going to initiate beta blocker or SGLT2 inhibitor at the onset. Rather, they have put forward that we can initiate with all the 4 drugs. We can either choose a ACE inhibitor, ARB, or ARNI, we can add a beta blocker, we can add a MRA and a SGLT2 inhibitor, then assess the patients and ultimately uptitrate the doses at 2 weeks interval. That is studying the safety, tolerability, and efficacy of rapid optimization of the heart failure therapies. The results will be published in the late 2021. Till then, we have to wait for other evidences. So I have told my part, and I will be waiting eagerly to hear my dear friend and colleague, Dr. Sumanta Chatterjee, to his part on rapid evidence-based evidence-based treatment of the 4 foundational therapies. Thank you.
Thank you, Dr. Bappaditya Kumar. It was a wonderful speech, and you registered a new trend that is going to happen in the next